Dr. Joshua Kimani, and Dr. Boniface Chitai. Please identify yourselves and so that we can get started. Dr. Gitonga, Dr. Joshua Kimani, and Dr. Boniface Chitai. Please identify yourselves.
You better, baby, shine your head as a clown. Don't let nobody ever put you down. Everything they do, we do it better. You need a bald man to love you better, baby. She says she want a bald man. She says she need a bald man. You know, once you go bald, no, you don't come back. So man, a bald man, come break this back. Oh, kili minywele kila mtu anazaki. Yule anani majaliwa. Mangapi wanazo na kichwani matope. Wengine nywele walinunua. So if you don't have it ready to be rasta, don't let your hair be your master. Keep it clean like a soldier. Somebody call the liar. Shine your head, it's a clown. Don't let nobody ever put you down. Everything they do, we do it better. You need a bald man to love you better, baby. Shine your head, it's a clown. Don't let nobody ever put you down. Everything they do, we do it better. You need a bald man to love you better, baby. Everything they do, we do it better. You need a bald man. Ukimpata napiga moto. No hair, don't care, I seen a former. No hair, don't care, as it was written in the beginning, and so shall it be. Never seen a bald man forsaken. It's written in the prophecy of humanity. We're gonna rise above all the hatred. Shine your head, it's the crown. Don't let nobody ever put you down. Everything we do it better. You need a bald man to love you better, baby. Shine your head, it's a crown. Don't let nobody ever put you down. Everything we do it better. You need a bald man to love you better, baby. Everything they do it better. You need a bald man to love you better, baby. Oh, baby. Everything they do it better. You need a bald man. Bald man, bound to the bone. We don't need no heaven. Everybody knows you want bald man, bound to the bone. We don't need no heaven. Everybody knows bald man, bound to the bone. We don't need no heaven. Everybody knows you love bald man, bound to the bone. We don't need no heaven. Yeah, yeah, yeah. Fiesta, forever, party, whenever, when we're together. Yeah, coming from the West Indies, and you know, so we giving them the best indeed. Anywhere we there, we do a flex on street, and the style what we do, no matter red stampede. And I interview, no matter question me, and you try never look in my direction, G. New bank job and no rejection stampede. Oh, coming from the set concrete, yeah. If you know me, I'm having the time of my life. Don't you slow down, beg you back. I wanna just party, yeah. I wanna just party, yeah. Yeah, but the wrist, yeah. Fruits and chalice on the mix. Matter fuck, put some passion in this. I touch turn it up just a little bit, yeah, yeah, yeah. Regular me pull up the bends and chop it up. What is up? Gas it up, flow like a aqueduct. New pop it on the ends and cut it up. Jack still got it up, wrapped and package up, yeah. Coming from the West Indies, and you know, so we giving them the best indeed. Anywhere we there, we do a flex on street, and the style what we do, no matter red stampede. And the interview, no matter question me, and you try never look in my direction, G. New bank job and no reject stampede. Oh, coming from the set right.
Get on your feet and live. None about strength and blessings I bring. And this one for all of my queens and kings. We are royalty, you play no them thing. I feel like the world really needs some change. This can't be right, whole thing feels so strange. Right now, all that we need is love. Some empathy, yes, this season two.
They say I'll never make it. The dreams I'm chasing, I'm all alone. I am destined for greatness. Time to embrace it, breaking the mold. Now they don't see you. When you start out, they gon' give you dirt. But you find out what you're really worth. Then you go hard and you deliver. They gonna try to take it all away. Can't nobody take it all away. No. Hurting you, loving you, hurting till you had enough. They say I'll never make it. The dreams I'm chasing, I'm all alone. I am destined for greatness. Time to embrace it, breaking the mold. Yeah, shorty. Tell everybody whoever down me, no matter how it's cloudy, I make it out proudly. Oh, and then when you get crowded, them stepping on me show, clearly them never know me. Sometimes the journey so long. Give thanks for the love that's around me. The love that my family show me. Yeah, we are rising in abundance. Still the rest of my keep with the gun on them. More love to my daughter than my son. And we can spread it over like a fountain. Yeah, they say I'll never make it. The dreams I'm chasing, I'm all alone. I am destined for great. Cool down some more, cool now, please me. Cool now, some more, cool down, love. Cool now some more, cool now, please me. Cool now some more. Boy, you make it too hard for me to stay here. Boy, you're making it hard for me to be your love. Talk about me, man, pick up your chest, I swear. If you don't get money, take it like that. When I face my fears, there's nothing I can do from here. For more in the first date, I make mistakes, I swear. For knowledge, I sacrifice my fears. Last time right here, I say I'm better and you can't compare. Yeah, so now you jump, we do it, but yeah, you know that can't see me outside. And me a day, walk a day, cry. Oh, now you jump, we do it, but yeah, you know that can't see me outside. Cause me a day, walk a day, cry. When I get down, we do it, but yeah, you know that can't see me outside. Cause me a day, walk a day, cry. When I get down, we do it, but yeah, you know that can't see me outside. Cause me a day, walk a day, cry. Oh, say, me a see a look from a cheddar. I know say nobody only protect. But if me and you get issues, I forgive you and I don't resent you. That's the dollar for you. I know say nobody only protect. And me I see the look for my cheddar. But if me and you get issues, I forgive you and I don't resent you. And it's simple the truth. I know lie to you. And I feel like if you dance it up, don't knock a water behind you. From my cheddar, you know me, I don't play. I don't lie to do. I know if you force it upon you. But you know say nobody do, you know. If you dance it up, if you just sweet, so like you jump, I do it, but you're crying. You know that can't see me outside. And me a day, walk a day, cry. Oh, now you jump, I do it, but you're crying. You know that can't see me outside. Cause me a day, walk a day, cry.
I didn't call you, no dancer. I said, we can call you some more. Yeah, you leave me no choice, so very soon I go appear for your demand. And you had that tight dress on. When I saw you last night at the club, even though I had my dark shades on, I was looking at you all night long. I'm in the middle of the street. How did I ever let you leave? Oh no, why did I drink this Hennessy? And I don't know what come over me. And I just want to make me come body. Don't to lose it to nobody, no. My body no go free. And I don't know what come over you. As you see me, so I know about you. I swear to God, you can come back to. You can come back to. Smarting, there's something I've been watching. I might just drunk or something. I'm rapping, loving like a monkey. A junkie for your loving. I must be high or something. But now it doesn't really matter because I'm in the middle of the street. How did I ever let you leave? Oh no, why did I drink this Hennessy? And I don't know what come over me. And I just want to make me come body. Don't want to lose it to nobody, no. My body no go free. And I don't know what come over you. As you see me, so I know about you. I swear to God, you can come back to you. You can come back to you.
I feel if I didn't love you. I can't take this kindness anymore. I can't take much lies anymore. It's trying for me to play with you. Baby, you're done for me, I'm too. Baby, you're a sufferer, soldier, killer of your own heart. If you treat me kinda, kept me closer, but we still part. It's easy with me. Drink it just to loosen myself up from what I can and shouldn't be. But now I'm in the middle of this.
Good morning. So good morning, everybody. Good morning, distinguished delegates. Good morning, those who are joining us virtually. Our speakers, thank you for coming on time. So welcome to day 2 of the National HIV Prevention Summit. I'm going just to lead you through the overview of today, what we expect today. We are going to have 2 concurrent sessions running starting now in this room and the other room. So the first session we have in this room is where we are going to look. This room will be looking at prevention packages and service integration, the importance of having one-stop shop for services for our clients. And in the concurrent room, we are going to have a session on COVID-19 versus HIV. Same but different. What adaptations are programs going through to ensure people access services during this time? What lessons are we learning around vaccine hesitancy, access for all populations and in all regions all over the globe, even as our scientists work around a HIV vaccine? How do we prepare for that? And also during this COVID pandemic, should we have another pandemic tomorrow? How can we protect the gains in the HIV response? So these 2 concurrent sessions are running from now up to 10:15. We will then have a break of 10 minutes. After the break, will again be followed by 2 concurrent sessions, session 9 and 10. Session 9 will be looking at the available HIV prevention tools. What is new? And that's why we always say every day, you now have options. At least each Kenyan should have an option for HIV prevention. We have so many choices which you should have. So we'll hear what is new, the new tools that are in the toolbox, in addition to what we have in the country and globally. Concurrent session will be on addressing barriers to accessing HIV services. How do we ensure that all populations have access to services, specifically the vulnerable and marginalized populations? And in that session, you'll see the importance of multi-sectoral approach, ensuring all stakeholders are on board to ensure that all populations are accessing services as we head towards the last mile. So those sessions we run up to 11:35. Then we shall have a break of 10 minutes again. After the break, then we shall head towards the last session of the summit, where we'll be looking at the key recommendations which will be given by our NAC CEO, Dr. Ruth Masha. And then we shall have official closing, the launch of the National HIV Prevention Coalition to provide leadership for HIV prevention in the country. So that's our session for today. And without wasting much time, at this point, I'll just hand over to the chair, moderator, and co-moderator to guide on this session. Over to you, chair and co-moderator. And this time, we also request those who are available here physically, please share the link with all your networks. Let people log on online because we have online platform where they can contribute, give questions, comments on various sessions, which the panelists will respond appropriately. So thank you very much, and over to you, Dr. Teresa and Sarah.
Good morning, everyone. Welcome. Good morning. Is it too cold? Welcome to this session. We are getting started on session 7. And in this session, we will be discussing issues around HIV prevention and the prevention packages that are available to us. We'll get some, we're expecting to hear some great lessons and as well as issues around service integration. So, as we prepare, I'll ask my co chair and the panelists who will be presenting, Dr. Patricia Olwach, Dr. Boniface Chitai, uh, Dr. Jane Thiomi, and Dr. Ruth Kamau to join us at the panel, please. Please come forward and join us at the panel. Sorry, I mean at the podium. Karibuni. The ladies have started and we're just expecting Dr. Chitai to join us. So, as we get started, allow me to introduce my co-chair for this session. With me is Dr. Sarah Malaba, the project director for HIV self testing with PSI Kenya. Sarah, I know, is very passionate about putting in energies and services for key populations, and it's really an honor and a pleasure to co-chair this session with you.
Thank you very much, Dr. Teresa Alwar, who is the chair of this session, and I have the pleasure of introducing her. Dr. Alwar works for UNICEF as the Child and Adolescent HIV Care and Treatment Advisor. She is very passionate about the adolescent girls and young women. She is also passionate about efficiencies in programming and integration.
Thank you. And we have a very honorable panel with us. It is indeed an honor and a pleasure to be with them. We will introduce each one of them as they come to present. And to start us off in this exciting journey on prevention is Jane Thiomi from LVCT, who is going to take us through a comprehensive package. Can a comprehensive package be sustained? And they're going to be sharing with us the dreams experience. Karibu sana Jane, and we'll just ask IT guys just to put up her presentation. So as Jane comes up, just to let us know that this is a timed session, so we'll try and be as efficient as possible. We're already a little bit behind time, but there'll be an opportunity for questions and answers later on in this session. Karibu sana, Jane.
Thank you, Dr. T. Could you go to the next slide and play the video? Okay. Welcome to Girl Effect. It only takes 3 minutes, and then we shall discuss. You could put some borrow. it's okay. Okay, for the sake of time, we shall continue. So thank you very much. That was supposed to be 3 minutes, took a little bit longer. My apologies. So I'm going to discuss dreams and my experience in dreams. Dreams is a partnership that was launched in 2015 uh, during the World AIDS Day by then the President of the US, Barack Obama. And the aim of dreams is to build girls or create girls who are determined, resilient, empowered, AIDS free, mentored, and safe. Dreams. So, what does dreams do? We implement a core package, and that core package addresses structural drivers that lead to girls contracting HIV or getting other sexually transmitted infection using drugs, multiple sexual partners, and many more, as you can see. Next slide. So this is the core package of dreams, and the package is trying to empower, or the purpose is to empower girls and young women to reduce risk of HIV, pregnancy, and also gender-based violence. And we work through social asset building. What we do, we have a platform, what we call the safe spaces, and we segment the girls according to age, according to their needs, and their stage in life. And we offer what we call social asset building, which include building their life skills, education skills, cognitive skills, financial skills, and social skills, among others. And we also provide services to the girls, individual girls, and some of the services we provide include the biomedical interventions like HIV testing and counseling, pre-exposure prophylaxis, contraceptive information, and provision for those who are of age, and then we address post-violence care. We also address the parents. If you go to that slide again, we address parents and caregivers, and we have parents and caregivers program, and we do social protection where we give education subsidy, uh, combined socioeconomic approaches, which include taking girls to vocational training, starting business for them, entrepreneurship, apprentice, the whole works of economic strengthening. Um, and we also reach out to their partners to address the risk of their sexual partners. We characterize the partners of the girls, and then we go out and reach out to them. And we also mobilize communities for change. In the mobilization for change, we offer one intervention called SASA, and we have implemented SASA in all the wards that we are working in at LVCT Health. And this is norms change, where we look at different powers within the community. There's the power within every individual. There's power over, there's power to, and there's power with. And the power over is the one that causes negative norms among the communities because somebody is using their power against the other person along free using their power. And we also implement school-based HIV prevention and violence prevention. And we work with teachers to implement what we call Beacon Teachers, is a TSC program. And we also offer what we call evidence-based informed behavioral interventions to those that are in school. Next. So there's a screening criteria or vulnerability criteria. And when we are enrolling girls, we enroll the most vulnerable and those that are at very high risk. And it is, according to age. Next. So far, we have reached 115, 310 girls in 4 counties. That is Migori, Homa Bay, Kiambu, and Nairobi through funding from Centers for Disease Control and Prevention, Kenya, CDC. And within this group, we have provided education subsidy to about 83,000. 36,000 have received some form of economic strengthening and approach. We have provided prep to 14,000. We have talked to parents and trained the parents on proper and protective parenting, 35,000 of those. And we have also integrated GBV in everything that we do. And this number of GBV, 17,225, this is just 1 year number, and 422 was sexual violence. That is year 2020, 2021. So there's some of the lessons learned is that you can't you have to be very holistic while implementing dreams, and you have to address all levels of the ecological model. Need to take a multi-sectoral approach. Need to address harmful cultural and gender norms. If you don't integrate GBV, you might not get all the full benefits of dreams. Then we work with community advisory boards, and that's a best practice. And then we partner with schools and parents. Next. Opportunities that are available is to increase the ownership of the counties, and also to have allocation for dreams and some of the AYP programming, because dreams mostly or focuses the main target, the main primary beneficiary is adolescent girls and women aged 9 to 24 and have to fit in within the criteria. The families are supported for those that are having girls in dreams, but some of the families have boys who there's nobody who is supporting. So we need to increase that. We need some policy reforms. It's very hard sometimes to register a company to do trade, to do things for vulnerable girls. Then we need gender transformative workplaces, meaning for girls who want to pursue what is commonly male-dominated careers. It is very challenging. We need to have networking platforms. Every time we go to any department of the government, they have some fund, but it's not known, but it is available. Could we have a platform where this is available? Then we need to revitalize the AYP, TWG, and work with ambassadors across all levels of the government. Next. So some of the stories, the quotes from the girls, that's a girl who graduated from the program, the first one, and she was able to access prep, and she was very happy, and she's happy to continue with her life. The other one is a girl who was taken back to school, had dropped from school, and she wants to become a doctor because they only have one doctor in their village, and she wants to become the second. And you can see she's 23, and she has gone back to school. Next. This is a young woman who was married, and sometimes she could not get money for food. She was taken for skilling. She learned how to do hairdressing and barber, and then she was able to open a business, and she's doing well in her business. Next. And this is another girl who is in school, had dropped off from school, and now is back in school. She was taken from Form 1 by dreams. Next. So some of the challenges is that in the communities where we are working, GBV and VAC are highly normalized, and they are very, very weak as community system that report violence. So what happens is when girls are reporting violence, they are already pregnant because they do not have system to report in good time. We still have very vulnerable boys, and I think they should be targeted. The cost of implementation is also high and cannot be sustained through donors alone. We need the government to invest heavily. And then that age of girls, they're very mobile, and sometimes the interest shift very quickly, and yet they're at high risk. And then data correction, we have a lot of data, and we only report very few indicators, like HTS, like GBV, very few indicators are reported. And yet there's so much data that can be used to learn and improve programming for adolescent girls and young women. Last one. So yes, we can sustain a comprehensive package, but what we need is a greater investment. We need the government to invest and other partners. Programs for HYW must be comprehensive to tackle GBV, HIV, and pregnancy using combination HIV approach. and they must be multi-sectoral, so better ownership and coordination by the government, and they must be implemented at scale and sustained over a period of time. Thank you very much. Thank you. Those are partners we've worked with.
Thank you very much, Jane. Please take your seat at the podium.
Thank you, Dr. Jane Thiomi, for highlighting for us the prevention packages for adolescent girls and young women. Our next speaker is Dr. Patricia Olwach, who works for USAID and is going to be speaking to us about integration of PrEP into existing services sustainability. Welcome, Dr. Patricia.
I saw him beckoning Jane to remove the mask. That's why I've removed. Good morning, viewers, and good morning, the audience that is here with me. I hope you can be able to hear me. Just by introduction, I'm Dr. Rose Patricia Olwach. I work for USAID, but for the last 15 years, I've worked for CDC in HIV prevention, care, and treatment, while I hold some 20 years with me in HIV work, having been one of the pioneer people who actually started PMTCT in this country. And we launched PMTCT, incorporating it into the government services. And then I moved on to HTS, and I've worked on major guidelines and implementation of HTS, moving HTS from 36% in 2007 KAIS to 72% in KAIS 2012. Then I moved on to prevention of HIV from adolescent girls and young women, worked on DREAMS, and I'm glad that Jane has talked about DREAMS, a very good program that needs to be embraced. Then I went on to PrEP, and I've worked on major strides in PrEP scale-up in this country. Now I'm working for USAID. Next slide. So I'm going to take you through this presentation, which is PrEP scale-up, integration into existing services, both in facilities and community services for sustainability. And I want just to look at the background, why integration is important, and the policy environment. Do we really have a policy environment? Please don't move too fast. Integration provision from PrEP implementation. And then we look at a few examples. We look at service delivery options and examples, and then call to action. And then the slide that you have on, we know the prevalence of HIV in this country, and we know that women are disproportionately affected by HIV than their male counterparts. And we also know that Kenya is striving for epidemic control. And we also know that PrEP is an effective HIV prevention strategy that works well when taken well. And we also know that clients at risk of HIV are readily available in our facilities and communities. And these are clients who seek other services, including even reproductive health services. So why integration? Next slide, please. So we want to integrate PrEP into the existing services because the client comes to you coming with headache, coming with stomachache, coming with whatever they want to explain, but they are also probably at high risk of HIV. So we want to take that opportunity to be able to talk about HIV and to talk about the modalities and the products that are available for prevention of HIV. We know that integration is effective, it's easy, it is holistic, and it actually saves time for the client. Plus, when you're talking about PrEP, PrEP is a new product, and it will normalize PrEP. When you talk about PrEP at every service delivery point, it will normalize PrEP and it will take care of the myths that societies and communities hold. And more so, it will lead to sustainability. Next. So what is the landscape? Where are we coming from? And lest that we forget, the policy environment exists and has existed since way back in 2009, when there was the development of the National Reproductive Health and Reproductive Health and HIV and AIDS services together. And this was anchored on Healthcare Policy Framework of 1994. It was anchored on NHSSP 2 and NRHP 207, and then KINASP 2, which was from 2000 to 2010. Next. So in that strategy that I talked about, the National RH and HIV and AIDS integration, it talks about integration into antenatal care, family planning, MCH, and postnatal, post-care rape, youth-friendly services, TB, and STI. But it also talks about integration into community services like community distribution of FP services, community midwifery, and home-based care, including OVC. So although PrEP was not available at that time, the message that we need to take from here is that that strategy laid out the foundation for anchoring or introducing PrEP, because it talks about integration of HIV and RH services. Next. Then came PrEP. Later on, we know that we had demonstration projects prior to 2016. Then we had the ART guidelines incorporating PrEP, which was launched in 2016. And we had the first PrEP girl getting, or rather initiating PrEP in dreams that Jane has taken us through in the first quarter of 2017. And that was actually December 2016. And I remember it was given by LVCT, because one of the interventions in dreams is that we give PrEP for those who are at substantial risk. Then, of course, that followed the national scale-up of PrEP that we know now. So we went ahead, next slide, we went ahead and developed implementation toolkits for PrEP. And in the implementation toolkit that was developed in 2018, actually gave provision for integration of PrEP into the various services that you have in the community and in the facility, in prevention centers, in pharmacies, in standalone DICEs. DICEs is drop-in centers, mainly used by key populations, special clinics that you find in facilities, MCHFP and ANC clinics, youth-friendly services, and comprehensive care services and outpatient units. So that provision already existed, that PrEP needs to be integrated. It need not be a silo and vertical program. So this schema, I'm sorry those colors cannot be seen well, but it talks about demand creation. Where do you do demand creation? Do it in HTS centers, do it in outpatient clinics, do it in special clinics, do it in youth-friendly, do it in DICEs, and even the inpatient wards. Then you come to identification of users. As you do demand creation, you also identify those who are at substantial risk, and you can do this both in the community and in the facility. And that provision exists. She's telling me 2 minutes. Then provision of PrEP, again, follows the same areas. So what this slide is saying is that there was already provision for integration as way back in 2018. I said I'm going to share some examples. Jane has shared with us the case of dreams. So this is Dreams in Safe Spaces. Next slide. And you find a young girl with a service provider who is dressed like her. So the myths of are not there. So we do everything in the safe space. RH services, they get PrEP, they get all the other services that they need, as Jane has already alluded. Next slide. Next slide, please. And we also have rationale for integration into HTS services. And why? Because you find that the high of tests in 2019 were conducted among those who are aged 25 years. Among those, 4 million were in AGYW, young people 15 to 24. And these are the people who are greatly affected by HIV. And so there is need for us to integrate these two services so that the identification happens at HTS and then PrEP can be given. There is also compelling reason, next slide, compelling reason to integrate it into pregnant and breastfeeding women services, and this is in PMTCT. And what this slide shows is that in the year 2018, we had 7,800 new positives among pregnant and breastfeeding women, and about 1,000 were diagnosed after the first NC. If we were integrating PrEP into these services, these 1,000 probably could have gotten PrEP and they would not have been infected with HIV, assuming that they were first infected or newly infected. Then we had a learning forum for PrEP quality improvement in 2000. Another minute for me. We had, thank you. We had a learning forum for PrEP improvement, quality improvement in 2019. And the things that came out was capacity building, training, and competency of providers. Demand generation and mobilization, which is critical. PrEP is a new product, and so we can preach integration, but if we do not create demand, then it will not be taken up. Then data management and tools for reporting is necessary, and quality monitoring is important. Community, self, and provider attitudes are very, very important for us to change. There are people who still believe that PrEP will encourage promiscuity, yet not. And then the last bullet there is full integration and diversification of service delivery points was a major finding from that forum. And that is why we are talking about integration. Those are service delivery considerations. I'll not belabor on them. Next slide. So what are the minimum requirements for PrEP integration into these existing services? And the existing services we are talking about in the outpatient, in clinics, in PMTCT, in CCC, in whatever service that you are giving in the community and in the facility, you need to talk about PrEP. So training is important. Infrastructure reorganization will be important to incorporate PrEP. Commodity and lab networks. You need to do staff reorganization so that this is taken in. Referral and linkages is important. And then monitoring and supervision. Next. Next. Next, please. This is just showing you one of the assessments which was done to find out where we are with integration. And the finding was that we were far from integration. And so we want to talk about call to action next. Next. Those are PrEP resources. Next. Next. So you must be deliberate about integration. Integrate it so that you identify those who are substantially at risk of HIV, and specifically AGYW, pregnant and breastfeeding women, serodiscordant couples, men at high risk, and KPs of all typologies. And we must give targets to help people get where they want to get. Next. And if you don't give targets, people do not know where they are going. That is the essence of that slide. Next. Next. This is just a case showing monitoring where you start with a PrEP client at month 1 and you want to see whether he or she comes back and at the end of month 1 and at month 3. Next. So this is the most important slide. It is a call to action. What can we actually do to actualize PrEP integration into all services? There's a role for NASCOP, there's a role for donors, there's a role for counties led by the CASCOs. I'm glad that this room has many CASCOs. Facility managers, it is incumbent upon you to make sure that you reorganize, and implementing partners are there to support you, and service providers. And together we can achieve PrEP integration into all the services that we have. And thank you so much. I'm sorry, Madam Moderator. Thank you for listening.
Thank you very much, Dr. Olwach. That was quite detailed and apologies. Thank you so much, Dr. Olwach. That was quite detailed, and I think a lot of lessons from that presentation. At this stage, I'd like to invite Ruth Kamau. Ruth Kamau works with NASCOP, and she'll be taking us through the case of combination prevention in the case of prevention centers that NASCOP has set up. Karibu sana, Ruth.
Good morning. Welcome the team meeting physically and the virtual team. So I'll be taking you through the combination prevention. And just to give a disclaimer, as we are talking of combination prevention in this context, is not the HIV combination prevention, but the scope is much broader. Next. And this is the outline of the presentation. We have a background. Next. So we have the health, preventive and promotive services in the country that are offered in different divisions, ministry, with a lot of fragmentation. There's more focus on programming than focusing on individual. There exist gap in health. There are gaps in health information and education and prevention of common diseases. There is with the increase in population and rising disease burden, there is need to shift our strategies to more people-centered and focusing on prevention. And public health interventions have been seen to have better impact in this. Kindly, could you increase the font for me? Just and share, increase the font for me kindly. I'm straining to see there. Okay, sorry about that. There's too much light for me there. We can go back. So the public health interventions in prevention and promotive are significantly cost-effective in addressing health burden, disease burden. Next. So the rationale for these centers will contribute to the achievement of universal healthcare goal by creating an enabling environment for engaging and empowering people and communities. The centers are envisioned to increase access of health information and the overall desired outcome that people will become more aware of their health and take up preventive habits and services. It provide a one-stop shop for different range of services, and they will be integrated and people-centered. And the aim is to offer services in an environment that doesn't look like a hospital, or where people do not feel like they are visiting a hospital. Next. So the client flow, majority of the services will be offered self-service. So the client can come in, access health information through accessing a brochure or sitting down to watch a video on the edutainment facilities, and they can access their weight and maybe and walk out. In case they need to consult with a provider, there is a triage, they can walk in and have triaging where they can be done blood pressure checkup, anthropometric assessment, and then maybe cancer services, and they can walk out at any stage. The environment where a client can walk and walk out at time. Next. So the scope of services will, one, mainly information. So to provide health information, education on prevention and management of diseases. We have screening for risk factors, signs and symptoms of diseases, which will include STIs, TB, NCDs, mental illnesses, and HIV. We have service delivery. The provider there will offer some services. Will be health education, counseling. We have anthropometric vision of some maybe emergency pill, vitamin supplement, and some HIV prevention services, because the aim of this center was to increase uptake for PrEP services. So in those centers, we hope to offer HTA services, which can be done through distribution of HIV self-testing kits, condoms, counseling for PrEP and PEP. And then we have linkages. The final one is linkages to treatment and prevention services to the nearest health facility. Next. Implementation approach is phased. We have initial pilot taking place in 4 counties, that is Kisumu, Nakuru, Homa Bay, and Nairobi counties. The site selection, initially we were to renovate standalone VCTs that are not in a facility setup, but we were not able to identify these facilities. So in consultation with the CHMTs in these counties, we were able to identify facilities that are in highly populated areas, like near a bus stop, a market, or a busy street, and then linkage to existing facilities, because constructing a facility from scratch could have been a challenge. So we had to get land that is within a facility. And this was the site identified. We have Nakuru, we have Bondeni Dispensary, which is near a very busy bus stop, the largest bus stop within the town. The other one is in Kisumu at Jaramogi Oginga Odinga Teaching and Referral Hospital, not within the hospital, but near the gate, where somebody can access without having to enter the hospital. And we have Homa Bay in Kasipul Kambondo, and Nairobi we have in Kwajenga Health Center. So construction is at advanced stages. Next. So to ensure sustainability, NASCOP and Kenya Red Cross implementing a Global Fund grant were overseeing construction and equip the centers. Then we have developed training package and trained county TOTs, and we have developed branding guidelines, then continuously offering technical support to the counties. So once completed, the counties will take up the centers and they will have committed to provide the human resource, commodity supply to the facilities, supervision of service provider, and then ensure they are meeting the running cost for these centers, like paying bills for water and electricity. Next. And this is what we have been able to do. This is in Nairobi County at Kwajenga Health Center. The construction is in final stages. It's not yet complete, so service delivery has not commenced. This is Nairobi County. Next. This is Nakuru County. And this is in Homa Bay counties. And that's it. So we need to shift our focus on increasing awareness to health prevention and promote people to take up health prevention and promotive services. Thank you.
A hearty clap for our presenter who has spoken to us about something that I hope you find fascinating and extremely useful for what we are discussing today. She has outlined that this is all about a people-centered approach. And Ruth was the last presenter on this panel. Would like to open it up for some questions. I can't see any questions from the online audience. If you have any, please feel free to post them in the chat and we will be able to ask the specific presenter to speak to that. Are there any questions in the room? Yes, we have a question right there.
Thank you so much. I want to also add my appreciation to the presenters for the good job they've done. My name is Vincent Ojiambo. Been in the space of HIV prevention for about 2 decades, like Patricia said. I specifically don't have a question, but a comment to dreams. A very good presentation given by Gloria. And the issue, unless it was sorted out the other day, is that we have so many good interventions in this country that we all appreciate and recognize that are working. Dreams for a long time has lacked a home. And I don't see a better home for dreams than National AIDS Control Council. Because if you look at the interventions that were talked about, they were all multi-sectoral. So we need to institutionalize these gains and make sure that we scale them up and sustain them. And the only way we can do is having NAC take the leadership, leverage on the available resources in country, working with the county governments. When she's talking about issues to do with the trainings, we know that at the county level, we have the TVETs, and we can utilize this platform. When we're talking about the social protection at the national level, I know she didn't mention an intervention called cash transfer. It was one of the best interventions within this DREAMS program. And I know that donors will not and could not sustain this. But I know that the government has this opportunity through the social protection program. It's one thing I know, and I have been part of the planning of this thing for a very long time. We did it, but we could not scale it up. I would wish that that be scaled up. When we talk about linking these young girls, especially above 18 years, to jobs and employment, we know that the government has something about the contracts for young people. How can we coordinate and leverage what we have in country and make sure that we maximize? And as I complete, I know nobody wants to talk about this because we like the numbers, yes. We know that the girls between 15 and 24 years are more than 3 times recording high infections. When it comes to new infections, I mean. But what about the boy child? We are leaving this boy child behind. You talk to everybody, implementing dreams, and will tell you that we need to consider the boy child. Let's not leave the boy child away alone. Donors may not consider this, and I'm happy that I'm now in a space that I can tell you about this. The results, the funding for these programs is not necessarily going to be there. You will see a lot of flatlining or reduction, but government has an opportunity to do this. Thank you.
Thank you very much, Vincent, for that passionate plea. I think we heard that part of the outputs from this workshop is really to take on certain recommendations that will come from the floor. What Vincent has outlined is saying that a call to action by NAC to extend the house, find a chair, find a bed, find a standing place for the Dreams project, or for the work that Dreams is doing, not really the Dreams project, but the work that Dreams is doing. She's saying that Dreams has lacked a home, and the recommendation is that there is no better home than the National AIDS Control Council, because there's going to be opportunity to institutionalize and then scale up the great gains that have been realized through the Dreams project, as well as find ways and means to address the needy and the vulnerable boys. Thank you very much. Is there any other comment or reflection in the room? Yes. There's another one. There's a mic nearby.
Thank you. Could I ask the last presenter to clarify regarding combination prevention? And is it, she spoke about people-centered. Is it a deviation from the combination prevention that we used to know? And is it a new project? Because there are some centers that are being set up. They're in different stages of being set up. So is it a project or so? I think that was not very clear, so that we may be able to capture that.
Thank you for your question. It is not a new project. It is part of the work by the National PrEP program to increase access for PrEP and providing it in an environment that we are able to reach the vulnerable, those at risk within the community. So it's not a new program. Yes.
Thank you for that. I think there are no more observations and comments. I will take it back to the chair.
I want us to appreciate our panelists today. Let's just give them one more hearty clap of appreciation before we end this session. 1, 2, 3. 1, 2, 3. 1, 2. We're going into the end of this session, and I really want to thank you ladies. It apparently became an all-girl session. I don't know how that happened, but we are happy to take it on. Next time, hopefully we'll have a bit of gender balance here. And as has rightfully been said, we need to engage the boys and the men. So we'll take that on. So colleagues, both in the room and online, we have had this session on looking at prevention and just taking a step back to the theme of this summit. We really want to look at the evolution of prevention and heading towards elimination of new HIV infections. And what we have learned and heard from our panelists today is that it cannot happen alone. We cannot do it as a HIV response alone. There needs to be multi-sectoral engagement, It needs to be centered around the adolescents and the young people and the people at risk, not only adolescents and young people, anyone at risk. We need to integrate. The need for integration has never been more apparent. We have heard from all the panelists that even as we provide these services, there's need for other services to be given. We have seen that responses require us to intervene when it comes to prevention of pregnancy, post-rape care. In this session, we're hoping to hear a little bit more about the mental health issues, which also can be integrated upon. We've seen the opportunities to integrate in reproductive health interventions. We've seen the opportunities that can be taken even in nutrition services. And all this work can also not happen alone in the facility. It also needs to spread out into community. So we need to dig deep and to spread wide when we're talking about HIV. Really, combination prevention, as we've heard from all our speakers, is not just combination prevention of HIV, but also prevention and promotion of good health and wellness beyond HIV. And I think we all agree that we cannot do it alone. We've also heard that we need to target very well, understand our epidemic, use our data. We've been informed we have a lot of data and yet we are not using it. How do we tap into the data that we are each collecting in our respective programs and services that we provide that can inform us to improve our programming for prevention? So I've had a call to action around data to really inform our programming and interventions. What I've also heard is the need for engagement of others, caregivers, community leaders, and if we use the socio-ecological model, we have the person at risk at the center. So having a human-centered approach, and around that person in their communities, their families, there needs to be interventions. There also needs to be interventions in the system, and we've heard about system-related interventions that are working in the context of prevention. And then we come together as partners and as government to respond. Another call to action is how do we make all this sustainable? And we have to work together as partners and led by our government colleagues just to see how best we can take up the promising practices, scale them up, and sustain them for the good of prevention. So that is, in a nutshell, what we have heard from this session. But I'd also just like to ask these full ladies to give us one call to action when it comes to prevention. Just one thing we really must do in the context of taking prevention. So I'll start with Dr. Patricia, who I am not afraid to call my mom. She has been a mom to many in the context of prevention. So, Dr. please, one call to action.
Thank you so much, Teresa. You have said it all in your summary, very well articulated. Thank you so much. What a better moderator would we have had? Really, I think HIV started as a crisis in this country, and that called for the donor and compartmentalization of services. But as we approach sustainability, as we approach epidemic control, that Kenya is now being regarded as approaching epidemic control, we need sustainability. And you have said it all. We have done very well in the policy guideline and strategic framework documents. We need now to make them happen. We don't need other guidelines and policies and whatever. Well, to improve, yes, but we need now to make those happen, and therefore we need top leadership. This is a case where we really need top bottom, top leadership, commitment, guidance, and deliberate action that it should happen. And it trickles down from top leadership guided by NAC, going down that what are we doing about integration? Are we still giving services? Are we still having an HIV PrEP being given as a vertical service? Are we still giving family planning as a vertical program? But how do we put it together? Because we are serving the one person. So my call to action is, can we as a country have it work rather than getting more policies and guidelines? Thank you.
Can we have it work? Let's make whatever we have available work. Over to Jane.
So thank you very much. Again, I also want to say thank you to my friends seated with me and the one seated here and the one who only knows my name Vincent. So thank you very much. I can't agree more with what has been said. And most importantly, we must integrate GBV conversations, parents against children conversation across every integration point at all costs. If we don't do that, we may never gain the benefits that we expect or we would want to have. Thank you.
Thank you. Prevention is key. I believe the cost of cure, irrespective of disease, is higher than the cost of prevention. So there is need for us to repackage our preventive messages. We can learn from what has been done from COVID, that even the youngest child knows how to protect themselves from COVID. Can we go back to the basics and revolutionize prevention so that we increase awareness, and that way we maintain the health of our population? Thank you.
So prevention is key. The cost of cure is higher than the cost of prevention. And we can actually use low cost, high impact interventions. We need to integrate GBV and really look for the sustainable path for all this work and making all our policies and guidelines work. That really, ladies, thank you. And I honestly want to appreciate my co-chair, Sarah. And this has been, I think, an informative session. We want to thank the organizers of this meeting for allowing us to share this space just to learn a few more lessons about integration. And we just hope that what we have picked from here will actually help us move into the next steps of making our of really implementing our HIV prevention plan. This brings us to the end of this session. I want to thank you all listeners, those in the room and those online. Thank you for staying with us, and we hope that you take these lessons and use them in your respective areas. Asanteni sana, and God bless.
talk about the things. I wanna talk about the things where they feel. I know they say what I know me. So if I tell you say I like it, yeah. Got me confused, I'm in the mood. In my shaka, what you want me, I can do. Got me confused, I'm in the mood. In my shaka, what you want me, I can do. Don't want me a job. Will you see me, I'm a processor. I be that guy where you do me, be a man. I did for your house, so I'll be alright. Don't want me a job. Will you see me, I'm a processor. I be that guy where you do me, be a man. I did for your house, so I'll be
Something like eternity, then for eternity I give you my all. I'll make a little opportunity. If I be player, I go put them on pause. Mommy, do you believe in second chances? Mommy, do you believe in so dice? I've been looking for the one that I found her. I feel love when I look into your eyes.
Don't be a job. Will you see me, I'm a processor. I be that guy where you do me, be a man. I did for your house, so I'll be alright. Don't be a job. Will you see me, I'm a processor. I be that guy where you do me, be a man. I did for your house, so I'll be
My girl, she got a gun in her hand, and she keeps one in her man. Baby girl, I know what I did. You ain't gotta run the amount, so run the amount. Baby, I say run the amount. Let me know how I feel, so run the amount. You know I got a special spot to help you remember me. And every time you leave this spot, you know I get to see. She's bright like an electric bulb, so everybody gets to see. Yeah. And every time you leave this spot, you know I get to see. Yeah. But tonight you can call my phone. Tonight you can call me all night long. Tonight I represent the guy with the money who live fast, but still, baby, don't die young. Say tonight you can call my phone. Tonight you can call me all night long. Tonight I represent the guy with the money who live fast, but still, baby, don't die young. So tonight just go all the way with me, all the way with me. Tonight just go all the way with me, all the way with me. Tonight just go all the way with me, all the way with me. Tonight just go all the way with me. 2 seconds, everything done bust, oh. The kind of love I get for you, now I'm mad, am I too cost, oh. He asked me waiting I love for life. I said waiting no go touch us. So, every day nigga see my mama smile that make me the bumper. So, color picker, color picker, one be take a color picker, color picker, one be take a color picker, color picker, jammy take a color picker, yes, color picker. Let me say she like to dance a zonto, I don't like make you conto. Baby girl, you the mommy, you don't know. Baby girl, you the mommy, you don't know. Oh, yo, she said she give me get the love and tell me say I really, really don't know. I get girl, she the mommy, you don't know. I get girl, she the mommy, you don't know. Oh, for your mata, mo fo, mo fo. For your mata, mo fo, mo fo. For your mata, mo fo, mo for your mata, mo fo, mo fo. My Adama, give me special love, mama, give me your lolly. 50 bottles for my baby, me lolly. 50 syrup for my baby, me lolly. Ooh yeah. Say my baby, give me special love until the night, me lolly. 50 syrup for my baby, me your lolly. 50 bottles for my baby, me your lolly. Oh, yeah, want take a
a color bico, color bico, one B take a color bico, color bico, one B take a color bico, color bico, one B take a color bico, Angas minanzoitin lindaba. Angas minanzoitin lindaba. Give nigga access to VIP. Oh, wanna say kanya my flesh with nana. Oh, nothing is like. Say nothing chola ne groupie. Ah, una backbone no nami. Ala, say nothing chola ne groupie. Ah, una backbone no nami. Ala, izinja zempilo ma. Umuto titi, otiti titi. Ah, mama Elisa. Ufuna khala na ma Elisa. Relax, I'm so penica. Sama yo moody. Sama yo moody. Ah, mama Elisa. Ufuna khala na ma Elisa. Relax, I'm so penica. Sama yo
Angelina, you the good in my temperature. If you call, I go come deliver. I no go fall in your hand never. So now me you could love forever. I'm a cocky no feeble like that. I'm a Angelina, I'm a Angelina. Oh, me all down. Anytime when I see you for the club or the television, your body. Sure you know say the thing when you carry 50 kill somebody. You know I feel a vibe, you feel a vibe, so baby whine about me. Yeah. And I know you shy, but it's cool when we're making love. On the low, 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 on the low. Angelina, you the good in my temperature. If you call, I go come deliver. I no go fall in your hand never. So now me you could live forever. I'm a cocky no baby like that. I'm a Angelina,
My mind is for you, my heart beats for you. Every time when I think of you, I don't know. I feel loved again. I don't want to wait for days. Let me have you in my arms again, please. When they all said I can't have you, I proved them wrong. I came for you, and you were the ending one too. Mama, you know I still come through. Give me love, yeah. Bye bye, yeah. I just wish for your love. My mind is for you, my heart beats for you. Every time when I think of you, I don't know. I feel loved again. I don't want to wait for days. Let me have you in my arms again, please. Jackie, and it goes like, my mind is for you, my heart beats for you. Every time when I think of you, I don't know. I feel loved again. I don't want to wait for days. Let me have you in my arms again, please. When they all said I can't have you, I proved them wrong. I came for you, and you had done anyone to. Mama, you know I still come through. Give me love, yeah. Forever, yeah. I just wish for your love. My mind is for you, my heart beats for you. Every time when I think of you, I don't know. I feel loved again. I don't want to wait for days. Let me have you in my arms again. Please.
My day for me. Put it on my bed, body. Love it in the yellow heat. Separate the soul and spirit from body. Now you take me heavenly. 2170. My head is spin. My dead that every least. Liar, liar, liar. Tell I see behind you. Everything will concern you. Concern me. Sayati, you cannot delete. Girl, I see we here, everything will concern you, concern me. Side ya delete, you cannot delete.
My mind is for you, my heart beats for you. Every time when I think of you, I don't know. I feel loved again. I don't want to wait for days. Let me have you in my arms again.
Fresh and clean, fresh and clean. Fresh and clean, fresh and clean. Yeah, yeah, yeah. Someone must step on the scene. Oh, I'm so blessed and free. Rebel must step on the scene. Oh, I'm so fresh and clean. From I open my eyes, give thanks to the Most High. Give thanks, giving thanks for life. No stress in on my side. So when you come around, you can't hold me down, you can't kill me with no attack. Whoa, try your best. My life not stress, just all the vibe and ease. But you got to be a rebel. Keep your mind right, meditate for good measure. Read the Psalms a day to chase away the devil. Keep your heart. Your days can be better. You got to be a rebel. Believe on a rebel. Oh, you got to be a go-getter if you really want to take it to another level. Fresh and clean, fresh and clean. Fresh and clean, fresh and clean, fresh and clean. On the scene, oh, I'm so blessed and free. Rebel